My name is Pete Sloan. I'm a pulmonary and critical care physician in Baltimore, Maryland at MedStar Union Memorial Hospital. Today I'd like to review the evaluation and management of postoperative metabolic acidosis. The goals of our talk today will be that we should recognize the common causes of metabolic acidosis and the expected respiratory compensation in the postoperative patient. Appreciate the utility and limitations of bicarbonate replacement therapy for metabolic acidosis. Understand how to appropriately change the ventilator to assure appropriate compensation in metabolic acidosis. Metabolic acidosis is a process that increases the concentration of hydrogen ions in the blood and therefore lowers the serum bicarbonate. pH is usually, but not always, low in metabolic acidosis. When it's low, it's called acidemia, but can be normal or even high if there's a double acid-base disorder. For example, the blood gas 7.40 pH, PCO2 of 30, and bicarbonate of 18 is indeed a metabolic acidosis, but there's also a respiratory alkalosis making the pH normal. So this patient has a double disorder, has a metabolic acidosis, but has a normal pH. So metabolic acidosis is not equivalent to acidemia. Causes of metabolic acidosis really are only three. We either increase acid generation, we lose bicarbonate through either renal or usually GI mechanisms, or we have a problem with our kidneys, either kidney failure or a renal tubular acidosis where our kidneys cannot get rid of our acid load. How do we compensate metabolic acidosis? We compensate with a respiratory alkalosis, also known as alveolar hyperventilation, which causes a drop of PCO2. How low should the PCO2 fall is predicted by Winter's formula. What Winter's formula says is, when there's a metabolic acidosis, our predicted PCO2 should be approximately 1.5 times the bicarbonate plus 8 within 2. Here's an example. This is a metabolic acidosis, low bicarbonate, and acidemia. The PCO2 of 24 is approximately 1.5 times the bicarb of 10 plus 8. Well, 1.5 times 10 plus 8 is 23. 24 is close enough. It's within 2 of the predicted. So this is a Winter's formula compensated metabolic acidosis. Another way to look at this is the last 2-digit rule. For moderate severe metabolic acidosis, look at the last 2 digits and see if the last 2 digits of the pH are close to the PCO2. Had we done the last 2-digit rule for this blood gas, we would have recognized this was a compensated metabolic acidosis. So there's degrees of compensation to a metabolic acidosis. Starting with the second row, PCO2 is appropriate. That's the blood gas. The bicarb is 12. PCO2 is appropriately concentrated by Winter's formula, 1.5 times 12 plus 8 is 26, or by the last 2-digit rule. The last 2 digits of the pH very close or exactly the same as the PCO2. Now that we know that this acidosis is fully compensated, let's look at some other possibilities. All of these blood gases have the same bicarbonate of 12. All of these blood gases are a primary metabolic acidosis, but only this one is compensated fully. This one is overcompensated because the PCO2 is too low and the pH is too high. It's a primary respiratory alkalosis. This one is trying to compensate. The PCO2 is low at 32, but it's not low enough, and the pH is too low, so we call this a partially compensated or an undercompensated. Now things get bad. In this fourth one, there's a metabolic acidosis. The PCO2 is normal, so we call this uncompensated. Person's not hyperventilating, or we're not hyperventilating him enough, and the pH is very low. We look at this as an emergency in the sense that, relatively speaking, this person's in respiratory failure. This person may need to be intubated if they're not, or if they're on the ventilator, we need to raise up the ventilator settings. I'll discuss that near the end of the talk. Finally, we have the worst case scenario. You have a metabolic acidosis, the bicarb is 12, and the PCO2 is above normal. This is a double disorder. Not only is there metabolic acidosis, there is also a respiratory acidosis, and that makes the pH very low. This is a medical emergency because we have two problems: dealing with the metabolic acidosis, which is the topic of this talk, dealing with the respiratory acidosis, which could be the topic of another talk. But bottom line is you have an emergency and you have to bring that CO2 down one way or the other quickly. What is an anion gap? We define it as the difference between the sodium, which is a positive cation, and the chloride and bicarb, which are two of the most common negative anions. Now, the normal anion gap is not zero because we're not including all of the positives here. There's other ones like calcium, magnesium. We're certainly not including all of the negatives, phosphorus, so you'd be surprised if the anion gap came to zero with all of these exclusions. But in an average person, this is a little bit positive. Between 5 and 14 is a typical difference of the sodium and a normal chloride and bicarbonate. So what the anion gap is really measuring is unmeasured anions versus unmeasured cations. So because we have more unmeasured anions than unmeasured cations, the anion gap is positive, which is interesting to know. But what's really important is if we have a buildup of unmeasured anions, which lactate's an example, lactate has a minus charge on it. The anion gap rises. So lactate is one of the things that's not in the anion gap formula. I mean, we could measure it by checking the level, but when we say unmeasured anion, we mean it's not put into the anion gap formula. So if your lactate's rising, that's lactate with a minus side. The anion gap is going to rise because this part here becomes a larger number. I'm sorry, because the sodium becomes a larger number balancing the lactate, which is not in the formula. For these reasons, probably the most important thing to know on anion gap is an elevated or a rising anion gap implies the presence of an anion gap metabolic acidosis. If you knew nothing about anion gap except this one fact, I think you'd be okay. Causes of an anion gap acidosis are organic acids that accumulate, rising the anion gap, that are balanced with sodium. So sodium lactate, when that rises, sodium goes up, that's in the formula. Lactate goes up, that's not in the formula, so the anion gap goes up. So there's a list of 8. We use the mnemonic mud piles, but if you look at this list, a lot of these are ingestions, and the only things that happen post-operatively are renal failure, diabetic ketoacidosis, and lactate. But if you break that down, renal failure is almost never acute. I've actually never seen acute renal failure causing an acute anion gap acidosis. Diabetic ketoacidosis can happen, but we usually know about it because their glucose is high, they're on an insulin drip, or we can check the beta-hydroxybutyrate or the ketones. So in a nutshell, the overwhelming majority of patients that have an acute anion gap metabolic acidosis after surgery have lactic acidosis. And from now on, I'm going to focus on lactic acidosis when I talk about acute postoperative anion gap acidosis. So anion gap rises 1 point every time the lactate rises 1 and the bicarb also falls 1 at the same time. It's a 1-to-1-to-1 relationship. So here we go. A preoperative patient has normal chemistries. The bicarb is 24. You happen to check his lactate of 1, even though you don't need to. The anion gap is 8. They get sick after surgery. Their lactate goes up by 8. Their anion gap will go up by about 8, and the bicarb will drop by about 8. That's what I mean by a 1-to-1-to-1, or in this case, an 8-to-8-to-8 change of those 3 parameters. How about bicarbonate replacement therapy? Well, our ampule has 2 strengths. At our hospital, it's 50 milliequivalents per small 50 cc ampule. We can calculate the bicarbonate deficit with the formula base deficit, which is from the chemistries, times weight times 0.5. It's hard to, I don't want to explain where that came from, but 0.5 is the fraction of the body weight that contains bicarbonate. Half of your weight in water contains bicarbonate. But an example shows how to use this. If somebody has a base deficit of 10 and there's 70 kilograms, we use the 0.5 and you multiply 700 times 0.5. There's a 350 milliequivalent deficit. Nice number to know because we know there's 50 milliequivalents in each amp, so we know they have a 7 amp deficit. Why do we need to know it's 7 amp? It's kind of nice to know when you're giving 1 amp that you're giving about 1/7 of their deficit. It's much better than giving an amp and having no idea how that compares to the deficit. Now, when we give sodium bicarbonate ampules, every ampule has 100 milliosms because the actual concentration is 50 milliequivalents of bicarbonate, but bicarbonate is sodium bicarbonate. There's 50 milliequivalents of sodium, 50 milliequivalents of bicarb, so it's 100 milliequivalents for every 50 cc's. So on a per liter basis, it's huge. It's 2,000 milliosms per liter. It's very hyperosmolar, and when we give multiple amps, we almost always see hypernatremia. So beware, sodium bicarbonate pushes are very hyperosmolar. Now, what we do is if someone needs volume and they need a lot of sodium bicarbonate, we make the classic bicarbonate drip. We dilute 3 amps into a liter of D5W, and now it's isotonic and it should not cause hypernatremia. Well, prior to considering bicarb replacement therapy, consider the following, and let me tell you, this is by far, I believe, the most important slide. I don't usually use a lot of exclamation points. First and foremost, consider the underlying cause of the acute metabolic acidosis. Second, remember that most people with acute metabolic acidosis after surgery have a lactic acidosis. Therefore, all patients with an acute significant drop of serum bicarbonate should have a lactate level checked immediately, and if it's elevated or rising, they do require urgent evaluation. So what is the urgent evaluation of lactic acidosis? It's really a thinking person's thing. We have to think about it. So where does lactate come from? It's either an increased global production of lactic acid from generalized tissue hypoperfusion, such as systemic hypotension, pressor requirements, or vasoconstriction, or end organ dysfunction, as evidenced by oliguria, altered mental status, and modeling. The other possibility for the cause of acute lactic acidosis is localized production of lactic acid, such as extremity ischemia, where we find pulse problems, Dopplerable pulses problems, cold extremities, mottled extremities, or bowel problems. Ischemic bowel is an engine that produces tons of lactate. Actually, all of the patients I've seen with lactates over 10 to 15, virtually all have ischemic bowel, although some of them have just severe shock. Ischemic bowel can be evidenced by pain, tenderness, a rigid abdomen, bloody stools, or diarrhea, but these signs are not always present right after general anesthesia, so be warned, you may see nothing to suggest ischemia, and frequently we depend on imaging studies such as a CT scan of the abdomen if we're worried about this in the postoperative patient. Probably the most important thing about the evaluation is get thinking about this, but call the physician on call. What's the evidence that we should be giving bicarbonate under 7.1? There are no randomized studies to show whether bicarbonate is helpful or not, but the consensus is that we should probably be giving it to everyone because the low pH should be corrected in order to increase left ventricular contractility, responsiveness to catecholamines, improve arrhythmias, and improve vasodilation. How about higher pHs, 7.1? Still, no randomized trials have ever shown benefit, and some have shown no benefit. But because of lack of good clinical evidence to guide bicarbonate replacement therapy in patients with a metabolic acidosis and a pH over 7.1, any institutional protocol for treatment is purely empiric and not entirely evidence-based. So we're talking about the empiric approach to bicarbonate replacement therapy, not the evidence-based approach. It's not unreasonable to administer bicarbonate for losses in the moderate to severe range only if associated acidemia is present and provided respiratory compensation is addressed. So I'm going to show you 3 examples to take home this point. The first example is someone that has a metabolic acidosis that's moderate, bicarb of 12, but they're overly compensating, their pH is almost normal. Well, even though there's a temptation to give bicarb, I would recommend against it. We don't really need to give bicarb. The pH is normal, and really the only reason we're giving bicarb is to help the pH come up. Second example, here the pH is low, I might consider giving bicarb, but the metabolic acidosis itself is very mild at 20 bicarb. What's the problem? The PCO2 is high. So in this case, it's a mixed respiratory acidosis and mild metabolic alkalosis, so I would also recommend no need for bicarbonate, rather to address the respiratory. Should the patient go on BiPAP if they're not intubated? If they fail BiPAP, should they be intubated? If they're on the ventilator, should we raise the ventilator settings? Probably. If they're too sedated, should we cut the sedation, maybe give naloxone? But the theme here is don't give bicarb in this type of a case. Work on addressing the underventilation and you'll be fine. Here's the last gas. Severe metabolic acidosis, the bicarb is 6. The lungs are behaving themselves. 17 is just where Winter's formula predicts. Nice compensation, but it is pretty bad acidosis. It is reasonable to give this person bicarb. In fact, most centers will give bicarbs for bicarbs under 10 or pH is under 7.1. So even though the pH isn't under 7.1, the bicarb in the single digits is a usual indication to replace it empirically. Finally, my last slide. How do we leverage the ventilator to help acidemia associated with metabolic acidosis? Well, again, patients on a ventilator with a metabolic acidosis, we know the PCO2 should be Winter's, and we shouldn't really allow it to stay much above the predicted value. So let me give you some examples. Well, let me give you the formula. If they're on the ventilator and the PCO2 is higher than we like, we should raise the ventilator rate above the patient's actual rate using the formula new rate equals the current rate times the PCO2 that we have divided by desired. Very confusing, but let me use some words. Let's say someone's currently on assist control breathing at 10 and their PCO2 is 30, but we calculate it should be 20. The current PCO2 of 30 compared to our desired of 20 is 30 divided by 20 is 1.5 ratio. That means the current combined rate of 10 should be raised to 15. Another way of looking at this is that that's an inverse proportion. Raising the ventilator from 10 to 15, which is a 3/2 raise, will cut the PCO2 by 2/3, from 30 to 20. However you look at it, it's an inverse relationship and we can use this formula. The other option we have is in severe metabolic acidosis, we can consider making the ventilator our friend. We frequently intentionally overventilate the patient to a PCO2 below Winter's prediction to help bring pH up further. So let me just go back to this last problem here. In this patient right here, severe metabolic acidosis, even though the PCO2 is right where Winter says, we have an option that we frequently use to crank up the ventilator even higher, get this PCO2 down to 12, 13, 11. That will actually help bring the pH by overventilating someone. So that's an option, but I would discuss that with the pulmonary critical care or intensivist. So in summary, we went through a lot of material. Let me summarize. It's important to be able to diagnose acute metabolic acidosis in the postoperative patient and understand the expected respiratory compensation. Recognize that lactic acidosis is the most common cause of acute metabolic acidosis in this patient population. Appreciate both the utility and the limitations of bicarbonate replacement therapy and ventilator management in managing patients with acute metabolic acidosis. And the most important point, if there's only one thing to remember, any patient with a significant elevated or rising lactate level requires urgent evaluation as to the cause of the acidosis and requires early institution of the treatment of the acidosis itself as well as the root cause of the acidosis. I thank you for listening. Good luck with everything. Bye-bye.